I'm going to ask the first one to Dr. Gore, which was a question raised at the last session. And it's a question about how do you find a good, however you want to define good, physician? How would a patient find a good surgeon? And if you want to extrapolate that to a radiation oncologist or a medical oncologist, but I think it's a concern for patients. How do they get information about quality of care? John?
That's a fantastic question, and I think that's one of the hardest challenges someone newly diagnosed with prostate cancer faces, because we get care where we live. So we get care in our own neighborhood, in our own community. And this is where some of our local prostate cancer support groups, I think, are an incredible resource. I don't think enough men, and this is sort of a male quality, reach out to some of these support groups, because these are incredible intellectual resources. And when I go to some of the local support groups, one of the first pieces of advice I ever hear some of the support group leaders giving is get a second opinion. I always think, especially with prostate cancer where you have the luxury of a little bit of time, I always think that having more big brains think about how you can do better is always a good thing. So I always advocate for second opinions, and I think not enough men take advantage of these support group resources.
Okay, questions?
Comment on the macrobiotic and vegetarian people's use of cancer prevention, and also on the use of soy products which have natural estrogenic properties.
Yeah, I mean, there certainly are a lot of different things that in the laboratory and in small studies can show or have shown effects on prostate cancer, and certainly anything with phytoestrogens and the relationship with androgens that have on prostate cancer. One of the challenges that I see is that, and again, it's kind of along those lines from those select trials. Everything has a side effect. Everything has a counter effect, and I think everything in moderation is an important thing to do. And one of the challenges with any diet that people get put on, or any focused area, it's very difficult to keep up with these very strict diets for your lifetime. And I don't think it's just one thing in the diet that's causing prostate cancer. It's multiple things. We have many things that come together between genetics and our family history and our environment to cause the cancer. So I rather favor picking a reasonable thing that you can do, trying to reduce your overall calories, because then you are going to alter things, improve the better things in your diet, eat more fruits and vegetables, get antioxidants that way. Try to use, skim milk as opposed to whole milk. Little things to reduce the overall caloric and fat intake. That you can do day in, day out. We're all going to slip and have the donut that they brought today, and that's fine. You have a lot of willpower. But this is a lifestyle change that you have to make, and I think if you can do that, you'll see the benefit from across a variety of dietary environmental factors.
Also wondering about organic foods versus non-organic foods, and recently growers have started with genetically modified foods. Probably hadn't been out long enough to study the effects of those yet. Also, alcohol. I've read that certain types of alcohol, like hard alcohol, whiskey, and certain types of beers are not very beneficial for cancer.
I think I'll actually let Jonathan talk about that, because
well, I was going to hand it over to my boss, Dr. Stanford, to talk about resveratrol. So.
Yeah. Because there was a finding.
Actually, we did some years ago publish results on red wine, just as a follow-up, showing that red wine was associated with a reduced risk of prostate cancer, and in particular stronger effects against the more aggressive forms of the disease. Based on lifetime consumption, there have not been any studies that have replicated that have been able to look at lifetime exposure. There are some studies that suggest that alcohol, other types of alcohol, may actually increase risk of prostate cancer. So I think it's an open question about beer and liquor. And I think we need more studies. I mean, it's a common exposure and a common disease, so more studies are needed.
Yeah, back there.
I have a question for Dr. Stanford again. What can we do now to determine the extent of the risk to our sons for developing the aggressive form of prostate cancer?
Right. So as you've heard this morning, we have more questions than answers. So I think we don't have the answer to that yet, but I think we're moving towards hopefully having what will become not just one genetic marker, but probably a whole panel of genetic markers that we hope will be able to identify those men in these high-risk families, most of whom are sons of many of you here in the audience, who you want to have the benefit of this genetic research, and that's what we're pushing for, is to have something to offer the next generation that would allow us to identify those men who are carriers of these rare high-risk mutations versus those that are not carriers. But we don't have those panels built yet, but I think we'll, over the next 5 to 10 years, there'll be a lot coming. At the moment, what we can say is that we know, because of family history, those individuals are at least at a 2 to 3-fold higher risk of developing prostate cancer compared to men in the general population who don't have a father that's been diagnosed with prostate cancer. So at the moment, what we would say is that that is an indication for beginning early detection and screening for the disease, which is one of the best hopes we have at the moment until we can find better markers other than the early detection for actually finding high-risk men and then hopefully being able to provide them with some dietary intervention, some other prevention, diet, medication, or whatever that might reduce the risk, particularly in these high-risk men.
Yes, some years back there seemed to be some, at least theories about higher rates of cancer in the Pacific Northwest due to lack of sunlight and vitamin D, et cetera. Has that ever been followed up on, and has it been dismissed, or what's the answer?
Well, actually, we have a paper that's almost ready to go for submission. So I think it's not unique to the Pacific Northwest. There's always been this question about whether vitamin D plays a role in prostate cancer, because we know that African Americans who have a higher risk of prostate cancer actually don't absorb UV light sufficiently to have sufficient levels of circulating vitamin D, for example. We also know that elder skin, if you will, doesn't absorb well enough, so that the elderly have lower levels of vitamin D, and we know that prostate cancer incidence is highest in the elderly, right? So there's a lot of evidence that vitamin D may play a role. There's also a lot of cell line evidence that it would have beneficial effects to reduce the rate of cancer cell growth, if you will. We've looked at vitamin D in relationship to risk of prostate cancer. The results are still unconfirmed, if you will, from study to study. There's variation. We've recently completed a study where we went back and we measured circulating levels of vitamin D in a fairly large group of men with prostate cancer to look at whether vitamin D levels would predict for recurrence, progression, or fatal outcomes, and have not really found that vitamin D is predictive for adverse outcomes.
This is for Dr. Wright. Two things. One is, in the vitamin E study, do you know which form of vitamin E was used, alpha or gamma? And the other one is, you said less progression in metformin, and how is the progression monitored, by PSA?
Yeah, so great questions. For the second question, yes, it was based on PSA progression in both the using a different definition for radiation and surgery, but the reduction in biochemical recurrence after primary treatment. And the mechanism we don't actually know. Is it through lowering levels of insulin and improving your glucose, or is it a direct effect on cancer cells in particular? And there's a lot of preclinical work being done to try to figure that out. And I don't know the answer to the vitamin E one. I'm sure somebody else does that can comment on that. But that's a great question.
You're doing great work, and we really appreciate it. I'm curious about how you are separating or isolating these factors. That the takeaway is the health piece and exercise, obesity, nutrition, but how do you isolate family behaviors that are passed down from generations to the next generation from, you know, diet or lifestyle factors? How do you separate individually when you're looking at the whole picture?
Yeah, it's a perfect, great question, and there's not a great answer for it. So we certainly, I think, one of the main themes today is personalized medicine, and how can we focus directly on what you're doing. And that's why, again, it's not a one-size-fits-all approach to people, because we do bring, as Dr. Gore just said, our nature and our nurture to do what we have, the bringing together genetics and environment, and we're doing a lot of things to try to figure that out. But again, I think it's the take-home for all of us is each individual patient is unique, and how can we help that person?
Some years ago, Fred Hutch published a paper on the role that calcium plays in tumor growth progression. Can you bring us up to date on that, because that's quite old?
That was not me, but I can just comment that there have been multiple studies that suggested the excess calcium intake and excess calcium in the blood would be a bad thing in terms of increasing risk of prostate cancer. And there are multiple studies that are consistent in showing that effect. And I'm not aware of any really recent studies, but I know there's a big group here that have gone back to use the blood samples and data collected from the PCPT and the SELECT study that Dr. Wright mentioned to try and look further at some of these factors in those study populations. But I haven't seen any publications recently on that.
I just want to comment that one of the challenges too with that is that calcium, vitamin D, and cream, more heavier things that have more fattening foods that have a lot of calcium in them. It's hard to separate out. Kind of getting back to the idea of what is the little thing that's causing it, and so one of the challenges with the calcium stuff is separating out all of those different factors, because they're all going to have an individual effect on the overall risk probably. So, and it's hard to completely adjust away those levels as well.
So unfortunately we're out of time. Want to make sure you have plenty of time to eat the healthy, nutritious lunch that we're providing. A few things. Number one, I know you have a lot more questions. Feel free to track down these presenters. Number two, there were some questions raised in the cards outside pertaining to more advanced disease, and we'll get to those this afternoon. Number three, for those of you interested, we always welcome visits to the center, both the Hutchinson Center and the university. Jeff Walker, wherever Jeff is right there, and Colin Ware. Colin's way over in the corner. Feel free to track those individuals down if you want to arrange a tour. We're very happy to provide those. Also, the support groups will be having tables right outside here. I encourage you to go talk to them. So again, we'll break for lunch. We'll come back at 1:45. Thanks.